As you know, the foods that we eat contain certain nutrients that are absorbed and used by the body. Some elements of food cannot be used and therefore are eliminated by the body as waste. The bowel is the one that is responsible for the elimination of solid waste from the body. Defecation is a term that is used to, that means the process of eliminating waste material from the bowel. The waste material itself is called by various terms. You may hear it called stool, BM, bowel movement, feces, different terms for the actual waste material themselves. Hi, I'm Kathy Getrist, and today we're going to be talking about enema and suppository administration. I'd like to spend just a couple of minutes talking a little bit about the function and structure of the lower gastrointestinal system. As you know, when you eat something, it goes from your mouth down the esophagus and into the stomach. In the stomach, the food is churned and broken down into smaller and smaller pieces, and then it moves on to the small intestine. In the small intestine, the majority of nutrients in the food that we've eaten are absorbed into the bloodstream and are taken to all parts of our bodies for use. The material that remains continues to move through the small intestine and into the large intestine. In the large intestine, much of the water that is now in this waste material is removed from the large intestine and reabsorbed into the body. So by the time the waste material gets to the end of the large intestine and accumulates in the rectum, a signal from the large intestine goes to the brain and alerts us that it's time to have a bowel movement. And from the rectum, when there's an accumulation of waste material, then it is removed through the anus. The large intestine and also sometimes the small intestine is collectively called the bowel or the colon. Sometimes you'll hear it termed the bowel and colon. Constipation is a buildup of fecal material in the large intestine that's not easily passed through the rectum. Constipation occurs as a result of several factors. One of the more important is a sedentary lifestyle. People that do not exercise and primarily sit for their work or in their elder years tend to have more problems with constipation. Poor nutrition is another factor causing constipation. Folks that have a limited amount of fiber in their diet or eat highly processed foods or have a small amount of fluid that they're drinking tend to be more constipated as well. Another is lack of privacy. When you think about patients in hospitals or nursing homes, frequently they are not in private rooms but share a room with at least one other roommate, as well as there are strangers that are coming in and out of the room. And in our Western society, we tend to have our elimination needs met in privacy. So in a healthcare facility, it is much more difficult to maintain that privacy, and as a result is a factor in patients holding their bowel movement and becoming more constipated. Another consideration for constipation occurrence is a slow response time in meeting the residents' needs. Many times residents will have to put on a call light and get assistance to the bathroom or assistance onto the bedpan, and if that call light is not responded to in a timely fashion, the individual tends to try to hold it, and as a result that slow response time can cause them to become constipated. Constipation is a real common problem with the elderly and those that are chronically ill. Caregivers must immediately report lack of bowel movement or a complaint of pain or discomfort during bowel movements to the nurse. What is a normal amount of bowel activity for one individual may be different for another. It's common for some folks to have a bowel movement every day, and for others it's perfectly normal for them to have one every 3 days. So you need to know what's normal for the individual and to be sure to report other abnormalities from their normal to the nurse. A fecal impaction is a serious complication that is related to constipation. Feces stay in the end of the large intestine in the rectal area when the water gets absorbed, and it causes the feces to become very hard and dry. That's what is called a fecal impaction. The condition is very serious and may block intestinal passage of other waste material. It's very painful for the resident as well. It's important that you report to the nurse any complaints of pain, absence of bowel movements for a day or 2 or longer, as well as any liquid bowel movement. Now you might think if a person has a fecal impaction, how would you be concerned if they were having a bowel movement? What happens sometimes, and it can be a very clear symptom of an individual who has a fecal impaction, if they have a little bit of liquid stool that is being eliminated from the anal area. What's happening is that liquid stool, which is behind the impaction, tries to get around it and will come out in the form of liquid. So be certain that if you note that with any of your residents, that you report that to the nurse, as it's a good indication that they possibly may have a fecal impaction. Remember that it is the digestive system that prepares food for use by the body. Whenever disruptions in the normal process occurs, it can be serious. A fecal impaction is considered a sentinel event in a nursing home. Sentinel means that it's being watched for, and if an incident occurs, it's investigated to determine how it can be prevented from occurring in the future. Generally, if an individual gets a fecal impaction, it's an indication of inadequate nursing care of the resident in that facility. Laxative medications are some special medications that are ordered by a physician to treat bowel elimination problems. A laxative is a medication that loosens a bowel contents and encourages evacuation. It may only be given when a physician orders them, as there's dangers associated with overuse. Sometimes people think that more is better, and they will take a laxative on a daily basis, and it does not allow their normal bowel activity to work, and it can cause damage in the intestinal system. Laxatives are administered by the nurse, but many times the only way that the nurse can determine the resident's need for a laxative is by the accurate reporting and recording by you, the caregiver. It's essential to report each bowel movement that an individual has. You'll need to question residents about their bowel activity if they are up and about and able to go to the bathroom on their own. Now I'd like to talk a little bit about enema administration. An enema is the introduction of fluid into the rectum or colon. It's given to stimulate the bowel and cause the contents to be released. The kind of solution and the amount of fluid that's used for the enema are prescribed by a physician. In addition to constipation problems, Enemas may be ordered to clear the bowel before surgery. Sometimes enemas may be administered before certain x-ray procedures, things like colonoscopies or sigmoidoscopies. And enemas might also be given as part of a bowel retraining program for individuals who've had nerve damage. There are two main types of enemas. The first type is called a large volume enema. And as the name suggests, it is a large volume of fluid that is used with this type of enema, somewhere between about 500 and 1,500 cc's of fluid, which is well over a quart. So you can see this is a substantial amount of fluid. There might be a tap water enema, or the abbreviation TWE, which means that just water from the faucet is used with this large volume enema. There might be a soap suds enema, or SSE as it's abbreviated. With this type of large volume enema, a small amount of soap, usually Castile soap, is added to the water and administered to the individual. And the third type of fluid that's used would be a saline solution, and that's a mixture of salt and water that is comparable to the normal body solution of salt and water that makes up our internal fluid mixture. The second main type of enema is a small volume enema. This is much more commonly used, and with this type of enema there is only about 3 to 4 ounces of fluid that is administered. There are several types. The primary ones that might be used would be a phosphosoda enema or an oil retention enema. All of these solutions operate by creating a feeling of urgency in the bowel. Urgency is the term that's used to describe the need to empty the bowel immediately. There are some general considerations when administering an enema that I'd like to cover with you. The first, and probably the most important, is making sure that standard precautions are being used. Be sure to wear gloves while administering enemas and suppositories and while handling equipment and linens that have been exposed to feces. Fecal material may contain blood that can carry blood-borne pathogens. If the patient is to get up following an enema and use the bathroom, be sure before you give it that the bathroom is available and not in use. When possible, an enema should be given before the patient bathes or before meals. Don't give an enema within an hour following a meal, as the increase in bowel activity from eating makes it difficult for the patient to retain the enema solution. Always instill the solution slowly. If there is rapid installation of fluid, it's going to probably cause cramping and pain for the patient. If the patient does complain of cramping or pain, stop the administration of the enema, but do not remove the tubing from the anal area. Wait for just a few moments and then resume the administration of the enema when the cramping or pain subsides. Encouraging the patient to take some deep breaths during the insertion of the enema may help reduce the cramping and pain that they could experience. If the cramping, however, does not subside, then remove the tubing from the individual and report that to the nurse. You would never continue to administer an enema if the patient was experiencing pain or cramping. Lubrication must always be used on the tip of an enema tubing for ease of insertion. Consult the care plan or the nurse for the exact type and amount of solution to use and then any other special instructions. Also, you're going to want to consult with the nurse whether or not you, as a nursing assistant caregiver, are even in a position that you would be the one administering the enema. Not all facilities have nursing assistants do the enema or suppository administration, so check with your facility whether this is a procedure that is something that you would do. The best position for a patient to receive an enema is a left side-lying position. This is called the left Sims position. Fluid flows into the bowel more easily when the patient is on their left side, and if possible with the right knee flexed and on a pillow. At times, however, an enema may have to be administered with the patient on the bedpan and in a supine or back-lying position. The supine position can be used if the patient is unable to hold a fluid from the enema, or if they are unable to assume the left Sims position. Patients should never be given enemas while lying on their right side, or if they are seated on a toilet or commode, as these positions do not allow the solution to flow up into the colon. It merely collects in the rectum, causing dilation and the urge to defecate immediately. Things to remember specific to giving large volume enemas are, first of all, the temperature of the solution needs to be approximately 105 degrees Fahrenheit. Solutions that are too cold cannot be retained easily by an individual, and if it's too warm, it can cause irritation, pain, and damage to the intestinal mucosa. Also, the tube should be inserted only 2 to 4 inches into the rectum. Most tubings on enema containers will have a marking at the 2 and 4 inch point. Never force a tube into the rectum, as it can cause damage and puncture the intestinal lining. If you are meeting resistance when you're trying to insert the tubing into the patient's rectum, stop, do not force it, but remove the tubing and report it to the nurse. The fluid should be allowed to enter at a rate of about 5 to 7 minutes. That's slow, but the slower the fluid enters, the more the patient will be able to tolerate it and the more that you are able to actually give them. The bag containing the solution should be approximately 12 to 18 inches above the anus. A bag that's hung higher than that will create a lot of pressure, causing discomfort and increasing the urge to expel the contents immediately. If the bag is lower than 12 inches above the anus, it's probably going to be too slow and the solution will not go in. Now, I'd like you to watch a demonstration of administering a large volume enema. Explain the procedure to the patient and provide for privacy. In the bathroom, adjust the clamp on the tubing and snap it shut. Fill the container with warm water, 105 degrees, to the 1000 cc line. Open the packet of liquid soap and place in the water. Mix the solution gently using the tip of the tubing. Run a small amount of the solution through the tube to eliminate air and warm the tubing. Take the equipment to the bedside. Place a chair at the foot of the bed and cover with a bed protector, and place the bedpan on it. Elevate the bed to a comfortable working height and lower the side rail. Be certain that the opposite side rail is up and secure for safety. Cover the patient with a bath blanket and fan fold the linens to the foot of the bed. Put on your gloves. Help the patient turn to the left side and flex the right knee if tolerated. Place the bed protector under the patient's buttocks. Adjust the bath blanket to expose only the anal area. Lubricate the tip of the tube. Have the patient breathe deeply and bear down as the tube is inserted to relax the anal muscle. Insert the tube 2 to 4 inches. Never force the tube. If the tube cannot be inserted easily, get help from the nurse. Open the clamp and administer the fluid slowly. If the patient complains of cramping, clamp the tube and wait until the clamping stops. Then open the tubing to continue the fluid flow. Clamp the tubing when the container is nearly empty. Replace the cover on the tubing. Encourage the patient to hold the solution for 3 to 5 minutes. Place the patient on the bedpan or assist to the bathroom. Remove your right glove and raise the head of the bed to a comfortable height. Raise the side rail for safety. Place the toilet tissue and signal cord within reach. Remove your gloves and wash your hands. Return to the bedside and put on clean gloves. Remove the bedpan and place the cover over it. Cleanse the anal area with the toilet tissue, followed by soap and water. Remove the bed protector and discard according to your policy. Remove the gloves and wash your hands. Provide the patient with soap and water and a towel to wash and dry his hands. Replace the top bedding and remove the bath blanket. Put on clean gloves. Take the bedpan to the bathroom and dispose of the contents in the toilet. Have the nurse observe any abnormalities before disposal. Remove your gloves and wash your hands. Be sure the patient is left in a comfortable, safe position. The other type of enema is the small volume enema. There are a couple of different kinds of small volume enemas. The first might be an oil retention enema. Retention means that the oil is kept in the rectum for a period of time to soften the feces and lubricate the rectum. This allows the feces to be moved through and out of the body more easily. The solution in a phosphosoda enema causes irritation to the lower colon and activates the urge to defecate. The tip of a small volume enema is pre-lubricated. It comes from the manufacturer that way, so additional lubrication may not be necessary. In some facilities, you may be asked to warm the solution by placing the enema solution in a warm water bath before administration. In other facilities, you would be administering this enema just at room temperature. So check with the nurse in your facility to see which is the preferred method there. Now I'd like you to watch a demonstration of administering a small volume enema. Explain the procedure to the patient. Provide for privacy. Lower the head of the bed to the horizontal position and elevate the bed to a comfortable working height. Be sure the side rail on the opposite side of the bed is raised. Lower the side rail and cover the patient with a bath blanket. Put on your gloves. Open the package and remove the enema container. Have the bedpan and cover on the chair close to the bed. Assist the patient to turn to the left side and flex right knee if tolerated. Place the bed protector under the patient's buttocks. Expose only the patient's buttocks by drawing the bedding upward around. Remove the cover from the enema container. Gently squeeze to make sure that the tip is undamaged and to remove any air in the tube. Ask the patient to breathe deeply and bear down as you insert the lubricated enema tip 2 inches into the rectum. Gently squeeze the container starting at the bottom until all the solution has been administered. Remove the tip and place the cover on it. Encourage the patient to retain the enema for 20 to 30 minutes. Carry out the remaining steps as with the large volume enema demonstration. Rectal suppositories are cone-shaped, semi-solid medicated substances that frequently contain glycerin. They are approximately 1.5 inches long, and they work to stimulate the inner surface of the rectal lining, creating the urge to empty the bowel, as well as lubricating the stool for easier evacuation. Suppositories may also be used to administer medication. Sometimes when patients are throwing up and can't take any medication by mouth, they will administer an anti-nausea medication by suppository. These medicinal suppositories must always be inserted by the nurse. In some facilities, nurses will be responsible for insertion of the laxative type of suppositories as well that help promote bowel movement. In other facilities, however, you as a caregiver may be taught some special training to insert the laxative type of suppositories. Make sure that you follow the policy and procedure in your facility. Now I'd like you to watch a demonstration of insertion of a suppository. Explain the procedure to the patient. Provide for privacy. Adjust the bed to a comfortable working height and place the bath blanket over the patient. Apply your gloves. Position the patient on the left side with the right knee flexed, if tolerated. Expose the anal area. Lubricate the tip of the suppository as well as the finger to be inserted into the anus. Insert the suppository using the finger about 2 inches into the rectum. Encourage the patient to hold the suppository until he has a strong urge to defecate. Complete the steps as with the large volume enema demonstration. It's essential to be accurate in your reporting and recording of information about enema and suppository administration. Things that you want to be sure to include are the amount of the solution that was given. How well was it tolerated? Was there any cramping or pain involved? Was there any excessive flatulence? That's the term we use for gas. How about abnormal color or consistency of the stool? What was the amount of the stool? Was there any blood, pus, mucus, undigested food, or other abnormality present? If you are unsure of what to chart, or how to describe something, be sure that you check with the nurse. Save anything that looks unusual. Remind the patient not to flush the toilet so that you can see the results yourself if they're going to be using the bathroom. Even if you do not give enemas in your facility, you will often be the one who will put the patient on the toilet or bedpan and care for them after the enema or suppository has been administered. The appearance and composition of feces are important indications of whether or not the digestive system is working normally. Be sure that your body expression and your facial features do not show disgust when caring for patients' elimination needs. Remember that bowel activity is a normal bodily function. This requires the same care and attention given to all patient activities.